Hi, everybody. Welcome to another installment of the Health Law Expressions podcast. I'm Rachel Rameli. I'm here with my colleague, Leanne Mitchell, and we have an important issue that we wanted to give our audience an update about. It's very timely. It's something that we've been hearing about from our clients, hospitals around the country. So we thought now was the time to address this. And I'm sure once we start talking about it, this is going to be something that's been on your radar previously. Maybe it's on your radar right now. And that is privileging for those individuals who perform surgical tasks, who are surgical assistants, medical assistants, and RNFAs. This really has been 20 years in discussion. And Leanne, tell us a little bit about how this started way back in 2004 so that we know how we got to where we are today.
Right. So as Rachel said, this is a requirement that's actually been in place for a really long time. And the first time that it sort of came to prominence was a letter that was issued by the Centers for Medicare and Medicaid Services, their survey and certification group. And that's the group that manages the hospital surveys, which most hospitals have done by accreditation agencies on behalf of CMS. But a letter came out in 2004, and it referenced the fact that individuals who provided a medical level of care or who performed surgical tasks in the hospital had to be privileged. And at the time, again, 2004, I think that the initial fixation was on the medical level of care part of that guidance and advice, because at that point in time, a lot of hospitals were not privileging advanced practice nurses and physician assistants. So we focused on the medical level of care and made sure that those individuals went from whatever we had been granting them at the time, scope of practice, job descriptions, whatever. And we developed a delineation of privileges, and suddenly they were being privileged and going through the medical staff process. And the language was always there that said, or individuals who perform surgical tasks. But I really think that, and we talked about it from that point in time. We talked about it in bylaws projects and things like that. But that initial fixation was on the individuals who provide the medical level of care and getting the, sort of advanced practice providers privileged in going through the medical staff process. That went from just being in a letter from the survey and certification group to being specifically codified in the CMS interpretive guidelines. It's part of the state operations manual. The interpretive guidelines is the appendix that addresses surveys in hospitals and things like that. But that language is specifically in there. It does reference, individuals who perform surgical tasks. And it references in that language the types of practitioners that we would be talking about. And some of the problem here is also the terminology differs all over the place. So we know it includes, the typicals, the ones that we've always granted privileges to: physicians, dentists, oral surgeons, podiatrists. But the language does reference RNFAs, registered nurse first assist, surgical technicians, and then when other, like PAs may perform surgical tasks and be in the operating room too. But it's really this category, this subcategory of whether you call them surgical techs, you call them surgical assistants, some places call them first assists, RNFAs. All of those individuals are definitely encompassed in this expectation that they're performing surgical tasks and they are to be privileged to be doing that particular thing.
So I think that, everybody saw this, right? Everybody in 2004 knew that this letter had been put out there and that CMS was, I don't know if they were changing their standard, but they were announcing, hey, this is what we expect. We expect privileging for these kinds of things. But in this specific letter and in the interpretive guidelines that came from it, although they said things like, surgical assistants and RNFAs who perform important surgical tasks, there was a lot of debate about, well, what's an important surgical task, right? So if somebody holds a clamp, or if they do the incision, or what if they do suturing? Is that actually an important surgical task, or do they have to be doing really the medical judgment part of the procedure in order for that to be important? And there was not a lot that was forthcoming from CMS in the years that followed. And so there was debate and nobody really knew. And so there was a lot of like non-movement on this over the years, and different organizations felt different ways about it. Some started privileging these kinds of medical assistants that were doing surgeries, and some didn't, and thought, well, I don't know what to make of that. It doesn't seem like what they're doing is important at our facility. It's not such an expansive type of practice. How do you decide what's important? Notably, there has not been any definition of what's an important surgical task in that specific standard of the CMS conditions of participation. There is, however, another standard within the conditions of participation that defines important surgical tasks, and that is in the part of the conditions of participation that talk about informed consent. And in that part of the conditions of participation, they define important surgical tasks as including things like opening and closing, dissecting tissue, removing tissue, harvesting grafts, transplanting tissue, administering anesthesia, implanting devices, and placing invasive lines. So, as you know, if you've worked in this industry for any period of time, since 2004, we've seen a lot more requests for permission or privileges or whatever it is at hospitals for individuals who aren't physicians or who aren't PAs or other practitioners to start doing some of these things, to be more involved in helping with these types or portions of the procedure. So that has really started to generate over time more and more discussions of, if they're doing this, if they're harvesting veins, then do we need to grant them privileges? And I think there's good argument that when you combine the interpretation of the two standards, well, probably yes. And so as time has passed in the past decades, Leanne and I and the other attorneys at Horty Springer have been having more and more conversations with our clients about that. So, well, what's changed now in all those decades of discussion?
So 2 years ago, CMS basically said that they were going to take a tighter look at the entities that they grant deemed status to. So they're going to take a tighter look at the accrediting bodies that they grant deemed status to, who are supposed to be coming in and surveying hospitals against the CMS, your accrediting bodies standards are supposed to incorporate and be consistent with what CMS expects in the interpretive guidelines. And CMS basically said, well, we're going to take a closer look at all of these accrediting agencies that we've granted deemed status to, and we're going to look at these things. Yes.
Just in case there's anybody listening who this is somewhat new to, what's deemed status?
Deemed status means that these are accrediting bodies that CMS have said will survey hospitals to an equivalent standard as what is expected in the interpretive guidelines. So you've got to get approved, you've got to be granted deemed status, and then when you hospital are accredited by a deemed status accrediting body, that means CMS is not going to come in on its own and survey you against its standards unless there's cause to do so outside of the accrediting process.
So only some specific named hospital accrediting bodies around the country have deemed status, and Joint Commission is one, DNV is one,
HFAP
was one.
is one,
yes.
HFAP.
So if you are accredited by one of those organizations, even though they're private organizations, CMS says that's good enough for us. We're not going to survey you separately. If you have that, you are deemed to be in compliance with the CMS conditions of participation. Right. So we know CMS sort of gave a warning, like you said, a couple of years ago to these deemed status accrediting bodies saying, we're not sure if you're up to the task. But
we're not sure if your standards are absolutely consistent with the things that CMS is focused on.
Right.
So as a result of that, accrediting bodies change their standards all the time.
Right.
Some with more fanfare and notice than others. DNV underwent a comprehensive update of its standards in 2023 and 2024. And they specifically built language in now to the DNV standards that is almost verbatim taking the language out of the interpretive guidelines speaking about these, individuals who perform surgical tasks. So now it is very clear that language has been incorporated into the DNV standards. And that is a significant change in terms of the language that's in that body's standards.
Right. So on the DNV site particularly, I think you can go back and look at every revision standard. And I think if you look at the 2022 standard, it has the old language from like the 2004 certification about privileging medical level of care, surgical tasks. When you look at the 2023 update, the standards now specifically mention RNFAs and medical assistants the way that we know CMS now expects and is in the interpretive guidelines. So, okay, so they went through this process, and despite this, we've had a lot of wait and see from hospitals, right? Yes. Why do you think that is?
Honestly, I think the bigger wait and see that hospitals took was not the idea of having to privilege these folks, because they're being granted something now, whether it's a scope of practice or, whatever we're doing now. So I don't think that it's so much the idea that we have to modify that to privileging. What I hear from clients is their bigger hang up about the idea of building them into the process is having to incorporate them into the peer review process, because having to do peer review flows from a grant of privileges. It doesn't have anything to do with medical staff appointment, medical staff membership. It is once you are granted clinical privileges, that practitioner has got to be incorporated into the peer review process. And the impression that most medical staffs have had is it's going to be difficult to do peer review on these folks and to get them into the process meaningfully. So at least the clients that I talk to, the bigger sort of holdout on the wait and see, and we're going to wait until somebody tells us we have to do this and then transfer them into a privileged process, was more about the peer review, I think, than the privileging piece.
And nobody was being cited.
Right.
So Joint Commission was not citing hospitals, or at least, we work with hundreds of hospitals and medical staffs around the country every year. We did not hear any reports of citations from the Joint Commission, from DNV, from CMS. It was silence. As long as you were privileging APRNs and PAs, yes. Organizations were like, we're not getting cited. We just had our Joint Commission survey. Nobody said anything, so it must be fine. So a lot of it was just, we're going to wait and see if enforcement begins, and then we'll know. So that's where we are.
Enforcement has begun.
That's right. So we have received anecdotal reports from our clients this year that DNV is citing for failure to privilege RNFAs and medical assistants who perform surgical tasks. And so that's really why we felt like this was the time to start letting people know that if you've been in the wait and see mode, now might be the time to look into it, because there are citations that are starting to be issued, as I understand it, true to how accrediting bodies normally are and how they probably should be. They don't give you a ton of time to come into compliance once you are surveyed and granted a citation. So you have to sort of pull it together really quickly. And for an organization, that can be a big scramble on, a few days notice to say like, hey, you've got all these people. So if they're going to do surgical tasks, we need to see that you've processed their privileges, and then to go through that whole process right away.
Right. And you have to think about it in these sort of phases. So if you are cited for this and you've got to come up with your plan of correction, you've got to deal with all of the folks that already exist. So, if you're a large health system, you may have, 100 of these folks who have been granted something else, or maybe just employees. So they're going through an entirely HR process, and you've got to figure out how you're going to transition them into a privileged status. Then you've got the folks that are out there and still pending. So it is not a small undertaking. So I do think that if I were a DNV accredited hospital, I would start thinking now about how to make that transition, because doing it in advance is a lot easier than doing it as a plan of correction and having to get it done quickly.
And I would not call myself a futurist of any sort. But, if DNV is pursuing this, we have to imagine the Joint Commission will be
not far
behind on that. So it's just a good time to revisit it and to think about, how would we really define the scope of privileges that we are allowing? Because it's, if you are already doing PA privileges for surgical tasks, it might not be the same scope that you're granting to RNFAs. You might need to really create a new privilege delineation that's a more limited scope that defines a different kind of education and training. And now might be the time to do that, when you can be methodical and thoughtful and do it at your own pace instead of having to do it as a corrective action plan. Now, I think that that's really the update that you need. If you need more details about this, we have an 8-page white paper that we have written that sort of details all of the CMS standard and how we got to where we are and what we're seeing. We're going to post that along with this podcast. So please feel free to visit our website at hordyspringer.com and look at that as part of this podcast. And feel free to reach out to us if you have additional questions. Thanks so much for your time.